And Sukriti's here. Let me just make her.
Valeria is scribing.
Yes. Hello, everyone. Can you make me co-host, please, to share the screen?
Hello, Steph. Huh?
Valeria.
Can you guys hear me?
Yes, we hear you.
Oh, okay, cool. Steph, you want to say hi?
Hey everyone, great to see you. Excited to be here today.
Learned recently that they want to share with the group while we wait for a case and discussants. Thank you, Maria.
Thanks, Gabriel. Thanks, Maria.
And Andrea, I feel like we haven't seen you in a little bit too, so it's great to see you as well.
Oh, thank you. I have a very hard time trying to move from Peru to Buffalo, but I'm here and I'm wearing my DX t-shirt. I'm wearing the CP Solver merch, so I am back.
That's awesome.
Congratulations on the move.
Yeah, oh, it has been crazy, but I think I am finally settled down a little bit.
Wonderful, great to see you. And I loved all your summary slides you had on Twitter from ACP. It was ACP.
Oh yeah.
SHI.
Oh yeah, it was crazy because it was ACP and CIM together. But yeah, I really like to summaries. Thank you.
Taylor, congrats on joining the Med Twitter community. I think I get the pun of your handle. Is it Thiotepa is a drug? But I actually have no idea what it does or what it's used for anymore. Maybe you can enlighten us.
Tay the PA. Taylor the PA.
Tay the PA. I get it. I thought it was a pun on Thiotepa.
You can tell people that, Taylor, and you'll sound very esoteric.
Okay, the PA. Okay, very good, very good.
Like yours could be Z the MD.
Okay, I understand now. Thank you. So does anyone have a case and who would like to discuss with us?
I'll just say as a disclaimer for today, we have dual caffeinated drinks here because we had reasons to be up for both of our kids, the new one and the old one last night. So that's why we're caffeinating. But I think the adrenaline rush will keep things going really nicely today. I'm excited to chat through a case with everyone.
We did a very extensive differential diagnosis for a crying toddler at 4 a.m. and as much of a physical exam as possible. And in the end, it turned out that it was similar to zoster without rash, where it was a diaper rash irritation issue that apparently was more symptomatic than the physical exam suggested at the time, but subsequently became much more clear cut. So just like the lesson for today is just like the rash in herpes zoster can actually be delayed and the pain can precede it by as much as weeks. Apparently a diaper rash can lag behind the actual discomfort. Very high yield stuff we're giving you here.
Hope that makes it on Twitter.
Yeah.
Probably all the parents and pediatricians are like, duh.
Yeah. He's fine now. He's great. All right. Mario is saying that recently visited Houston Medical Center, had no idea that BCM and MD Anderson were adjacent. Yeah, it's it's a pretty cool place. A lot of institutions kind of smushed together geographically, and it's actually makes it a lot easier for those of us who work at different hospitals to kind of not have to commute very far and be able to walk from place to place during the same day and stuff. Glad you had a good visit, Mario. We aren't prepared to kind of do any space learning and reflection on the recent CPS cases. So if anyone had a chance to tune in and see the neurology case from yesterday, please feel free to share any kind of a snippet of the case or a major take-home point. And we'll wait a couple more minutes to have some discussant buddies.
And it looks like Anne-Marie is happy to present a case that she had exposed to. That would be awesome. Looking forward to a lot of great teaching from it too.
Anyone see the case yesterday?
I watched the case yesterday. I was a bit distracted, but I think I can do like a quick summary of it if you want.
Please.
Well, the CC was abnormal movement and of just like one arm and one leg, I think. And they discussed like abnormal movements is just an entire fellowship of neurology. So it's like a very big, broad, anything under the sun. But mainly like the high points of it were like dividing the abnormal movements into like hypokinetic, hyperkinetic, and then looking for triggers, or we have like some things that sound more to us to like one pathology than others. So seeing like with an intention tremor, an action tremor, of course we're not like movement fellows, but we can characterize it pretty well and then like tell somebody who has much more experience of it than us. But after a couple of testing being done and everything, everything came back normal. So nothing abnormal in the CT scans, nothing normal in the EMGs, but like they did like a EEG, and the patient had epilepsy with no structural disease, because then once you get like epilepsy diagnosis, you have to look for the underlying cause, and then if it's like a structural lesion. So we've learned, most common cause of epilepsy worldwide was neurocysticercosis, but then there's this whole broad term of, epilepsy without structural lesions. And in this case, the patient was like an older patient. So one of the things that you will always have to consider with epilepsy with no structural lesions is, some sort of antibody. And then there's like 1,000 antibodies, every day we've been getting like more antibodies discovered. Not all of them are paraneoplastic, but that was like Aaron's concern. The patient had some sort of cancer, paraneoplastic antibody, epilepsy. The patient also had like other features, which, the patient had abnormal movements. He was having altered mental status going on, and then they were really worrying about a prion infection. They did all the testings and it came back as CJD. So it was a very memorable case. CJD is such a rare disease and it has so rare presentation. So, we don't really think about it, but anytime you get like rapid onset dementia plus anything, just rapid onset dementia, just make sure not to like miss out on it, because we've all learned, of the risk factors for acquired CJD, but unfortunately, there's cases of sporadic CJD without any risk factors. So always think about it with very rapid onset dementia, and then as a cool diagnosis of a cool differential diagnosis for non-lesional epilepsy, think about paraneoplastic or non-paraneoplastic antibody-mediated epilepsy, which is also really rare and can present with risk factors or no risk factors at all. So really good case.
Thank you, Maria. That was a great summary. Thanks for sharing with us. So we have a case. Noah's up for it. Simone, and I hope I'm not mispronouncing your name. What about you? Are you able to join us today?
I think Tay the PA.
Oh, Tay came forward. Okay, awesome. So Taylor, Noah, please introduce yourself, say hi, and we can get started.
Hi, everyone. My name is Taylor. I'm a PA. I work in internal medicine at Einstein Hospital in the Bronx. I'm actually coming off a night shift. I worked last night, but it's really funny because some days I don't work any back-to-back nights. I work one night and then 2 days a week. And some days I sleep like 8 hours and some I sleep 3. And I think like I had it in my head that I wanted to come to VMR. So I woke up around 12 and here I am. Yeah, pretty easy night, which is nice. I never use the keyword, but not too bad. Had my coffee, and I'm like a really big fan of the CP solvers. Just such like a safe space. I feel like discussing just like really challenges me because I'm still like fairly new as a PA. It's going to be 2 years for me in August. So just like challenging like my like thought process. It's just like really good to practice. It's definitely like helped me on the wards. And I'm trying to spread it around to my coworkers. I'm like, you guys have to come. So we'll see.
That's awesome. We're so excited to have you, Taylor. Thanks for being here. Noah, want to say hi to everyone?
Hey again, Noah. I'm Noah, 4th year med student, graduating a week from today, and then heading up to BI next year for internal medicine. I've actually got a friend coming your way, Taylor, for internal medicine. So hopefully y'all are interact. Yeah, and excited. I haven't been on the wards in a while, so it's nice to just discuss and refine and challenge myself again.
No, I listened to your diarrhea discussion and I was absolutely blown away. So I wasn't sure if that was you, but I'm really going to have to step up my game because I have discussed a few times and I feel like I've kind of just like stared at the screen and I'm like, but I feel like I've never gotten like dyspnea and like lower extremity edema. Like I treat heart failure every day, but I've gotten like rheum and I'm like, okay, great. But hopefully today will be a good one.
You're far too kind. I've heard discussions too. You crushed it. I mean, I'd be very down for a dyspnea case today, but I don't know. I think Anne Marie always has something up her sleeve.
And speaking of safe spaces and great learning opportunities, maybe I've been away too long. I couldn't help but giggle a little myself when Taylor was like, I was such a fan of your diarrhea discussion. Like only in CPS VMR, right? Is that the highest form of praise? But that's awesome.
I listened to your diarrhea were the exact.
Yeah, I listened to your diarrhea discussion. Let me get my giggles out. And then Anne Marie, do you want to say hi and just remind everyone who you are and we'll get going.
Hi, everyone. My name is Anne Marie Kumpfer. I'm a first-year hospitalist at UNC. So excited to present a case I actually saw pretty soon after starting here and was a kind of tough case diagnostically for me. There's a lot of background information, so I'll put some of that information in the chat just to help with that. Okay, is everyone ready? Okay. So this is the case of a 23-year-old female. past medical history of neuromyelitis optica on rituximab treatment, and kind of prior to admission had had a very complicated course. 4 months prior, presented at 26 weeks of pregnancy with painful mass in her urethra and was found to have hematuria and right-sided hydronephrosis. A urethral diverticulectomy was performed and a Foley catheter was placed. 2 weeks later, the urine culture Klebsiella that was appropriately treated. She was also found to have nephrotic range proteinuria and hematuria, and there was some concern for IgA nephropathy, but the renal biopsy was deferred just due to the pregnancy status. An extensive autoimmune testing at that time was negative. She was also found to have gonorrhea that was appropriately treated with confirmation of eradication on repeat testing. And then 3 months prior to this admission, she presented with a premature preterm rupture of the membranes and premature labor. A C-section was performed, but like after continued to have chronic pelvic discomfort, bladder spasms, and dysuria, and then had been following up with urology for these symptoms, had undergone a scope and was found to have a very friable erythematous vaginal vault and a large opening in the anterior vaginal wall. And basically the bladder was visible at that time with a friable mucosa, did not see ureteral orifices. An MRI showed that there was now bilateral hydronephrosis, but it had to be terminated early due to discomfort. Then 2 days prior to admission, she presented to a neighboring hospital where the CT showed concerns for hydronephrosis and wall thickening. She was treated and then sent home with cefuroxime, which she'd been taking. Urine culture showed mixed flora. But then she went home and had increased fevers up to like 101 degrees, increased lower back pain and chills, with kind of ongoing pelvic pain and dysuria, and so represented. And that is the end of Aliquot 1.
So heart failure.
Just what Taylor wanted, right? Heart failure and lower
Yeah.
extremity swelling.
Taylor, what a poor lady. I'm still like reeling from just processing what her experience must have been with all this. You want to pair up, Taylor, and just share your initial thoughts here?
Sure. So I guess kind of just leaving like the history aside, I'll start with like her chief complaint, which I guess is increased fevers, lower back pain and chills, and dysuria. So that makes me think of like an infectious process. So whether a UTI, pyelonephritis, those are like the two big things that are on my mind. So just like the general approach to like dysuria, you would check like a urinalysis, urine culture. You would assess for like CVA tenderness. The fact that she's having lower back pain could indicate that she, might have some involvement of the kidneys, which has to tailor your antibiotic regimen because not all of them will treat more systemically. So that's kind of like my initial thoughts, just like her chief complaint of these fevers, these lower back pain, and the dysuria. Now she obviously has had a lot going on. This painful mass, I mean, I don't know, was that like a cyst? Was that, I'm not really sure what exactly that was, or if it kind of just like went away on its own, or if it has any relationship to do it the whole picture. I'm assuming it probably does, because it looks like she, has this history of the hydronephrosis. She's needed a Foley. She's had Klebsiella grow in her culture, and just, in general, it's helpful to look at prior culture. Like with a patient who's presenting with recurrent infections, you could kind of look at the prior cultures and see what it grew and what it was sensitive to. Some people have XDR, so that's something to keep in mind. And then the nephrotic range, proteinuria and hematuria. Truthfully, in someone who's pregnant having proteinuria, that my mind kind of led more towards preeclampsia rather than IgA nephropathy, but that's just, kind of my initial thoughts. And then she has this friable mucosa. So when something's friable and bleeding, it's most likely inflamed. So, for her, I guess, my first, steps would be vital signs, make sure, see if she's septic or someone who, needs to kind of be addressed ABCD first and foremost. And then, yeah, those are kind of the initial thoughts. Just vital signs. I want to see how sick she is on the initial presentation, and then we can always go back and kind of tease out the rest.
Taylor, that was incredible. I think everything you said was so spot on, and you covered so much ground. I like that you just started with the most kind of proximate current symptom complaint and kind of thought about the differential for that. It's such a good way to not narrow in and get sucked into this extremely complicated history, right? And miss something that is just common and could be happening, and kind of lose your default framework for a common symptom. Honestly, this is one of the most complicated patients I've ever heard about or taken care of, even in this first aliquot. I can't imagine what's to come. But the reason is that there is both sort of signal and signature for potentially a systemic autoinflammatory or infectious disorder. There is the reality of an autoinflammatory kind of disease and severe immunosuppression. Anne-Marie, how long has she been on rituximab?
I think about a year. I think I'd last gotten it. I'm trying to remember if it was 3 or 6 months ago.
Okay.
But sometime within the last 6 months.
Gotcha. So there's definitely the possibility for a lot of potential opportunistic infections that happen when you deplete your kind of humoral antibody mediated immune system, viral, bacterial, and otherwise. And then it's one of the things that makes internists most uncomfortable, which is complicated, complex, multifaceted surgical and anatomic kind of abnormalities, right? Where sort of normal tissue planes, normal barriers, normal kind of pathways of presentation and complication and anatomic reasoning and thinking and functional reasoning and thinking are all screwed up, right? So that's kind of my biggest kind of reflection. And I really, Taylor, the other thing that you did well is just try to address each of the abnormalities and think of them conceptually, right? From the proteinuria to the friability and thinking about the inflammation and stuff. So there's just so much going on. I think a couple of additional things that I worry about even at this early stage is the hydronephrosis is clearly kind of progressing despite other things we're doing, and I'm not totally sure what's causing it. So trying to establish the actual mechanism of kind of blockage and increased pressures in the kidneys, and or depending on what the creatinine is doing, potentially relieving that that upfront, just like Taylor was thinking about some of the other kind of one step ahead anticipatory planning and stuff. That would kind of be behind my list. There's also this kind of specter of one STI with the gonorrhea that sounds like was appropriately addressed, but we haven't necessarily heard any kind of reassurance about testing or empiric treatment for other STIs that often, run together. So I think that would be important in addition to kind of the routine next steps, as well as really close, collaboration from the beginning with all of the kind of surgical consultants, OBGYN and neurology, in trying to help us better make sense of all of the anatomical kind of complications and stuff that she has. So I'm sure there's a lot more that could be said, but let's leave it at that and hear a little bit more from Anne-Marie.
Okay, so on admission, or sorry, I'll finish out. I don't have all the medications here, but the important one was the rituximab prior to admission. There was like a few other various ones. Family history, just say was non-contributory. Social history, sexually active with one male partner, kind of intermittent alcohol and tobacco use, and then no significant allergies. And then as far as vitals, on admission, temperature was 100.5 degrees Fahrenheit. Heart rate was between 105 and 130. Respiratory rate was between 18 and 26. Blood pressure was originally 94/50 and improved to 108/72 after fluids. And then the oxygen saturation was 98% on ambient air. As far as the exam, the significant things were just appeared uncomfortable, was tachycardic, but no murmurs present. The lungs were clear. The abdominal exam, there was some suprapubic tenderness to palpation, as well as bilateral CVA tenderness as well. A gynecologic exam was not performed upon admission. Neuro exam had some bilateral spasticity, as well as sensitivity, but that was unchanged from baseline. And then her skin, otherwise there was no visible rashes present, no synovitis, or like MSK involvement or anything like that.
And Anne-Marie, has she still had the Foley catheter in up to this admission assessment?
I'm trying to, I think it was removed in the interim.
Okay. Do you want us to hop in there?
I can give some, it's up to y'all. I can give some initial labs too, if y'all like.
Yeah, whatever pacing you think is good. If you want to give us a little more, that's great.
Okay. So lab showed a WBC of 10.1 with an absolute neutrophil count of 7.6, absolute lymphocyte count of 1.3, and then an absolute eosinophil count of 0.3. Hemoglobin was 8.5. Platelets were 455. Sodium was 138. Potassium was 3.8. Chloride was 105. Bicarbonate was 14. BUN was 14. And creatinine was 1, which was near recent baseline. Glucose was 101. Hepatic function panel was normal with an albumin of 0.3. Lactate was 2.5. COVID-19 testing was negative. And then the initial urinalysis showed a specific gravity of 1.01, moderate leukocyte esterase, 500 milligrams per deciliter of protein, large blood, greater than 100 RBCs, greater than 100 WBCs, and many WBC clumps. And I will leave it there.
All right, Noah, it's you and me. I guess, Noah, do you mind, before sort of jumping into your thoughts in general and the additional input we can give with the exam and labs? Such a complicated case. I think doing a problem representation could be really helpful. Do you mind doing that for that first segment that Taylor and Zavin discussed? And then maybe with that foundation, we can move forward together.
Sure. So let's see. I guess for that initial sort of HPI, I'd say a young female with recurrent presentations for, I guess with a known painful mass and recurrent presentations for urinary tract infection and known gonorrhea positivity. And do we know if they were properly treated, Anne-Marie? Just to jump in, sorry.
Yes, it was appropriately treated and confirmed to be negative on repeat testing.
So I guess I'd still include that with known prior gonorrhea and known UTI, admitted for I'd say likely a subacute presentation of lower back pain in the setting of systemic inflammation, with, I guess, maybe concerning for hydronephrosis and possible continued infection. I know that's not too cohesive, but trying to fit everything into sort of a couple sentences at this point.
Very hard to do. Thank you for doing it, though. I think it just helps sort of us go forward. I think the only tidbits I might add is, she's peripartum and has autoimmune disease on suppression. That may just help us rank kind of autoinflammatory and infectious things. But that was beautifully done, Noah. Take us forward from where Zavin and Taylor left off.
Yeah. Well, this is a lot to process, but I guess I'll start in the lower left corner and work my way through, trying to think through the labs, give myself a little time to think through the exam and labs. I think something Zavin said before really stuck out to me is that the rituximab is, and in the long 6 months of treatment of rituximab is definitely concerning for some sort of immunosuppression. We don't necessarily see that reflected on the labs in terms of absolute neutropenia, at least from what I can tell. But we could consider like reactivation of certain viruses or certain mycobacteria that could be concerning, especially if they were seeding in the past, or just trouble clearing a common UTI, or something seeding like pyelo. The other interesting thing here is this history of neuromyelitis optica. I'd be interested to know what the prior neurologic deficits were, because even though we commonly think it's associated with cranial nerve palsies or specifically like an optic neuritis, I think it can cause spinal cord lesions and like a transverse myelitis picture, and that exam is concerning here for something like that. So I'd be wondering if there were involvement of, S234 or any lumbosacral component that could affect or cause this hydronephrosis, maybe. Nothing specifically else in terms of her past histories, jumping out at me. I would want to know whether her male partner is monogamous, because even though she's been treated for gonorrhea, if the male partner wasn't necessarily treated for those STIs properly, there could be, a reinfection or some other risk as well. In terms of this exam, really what jumps out to me is that this patient is sick, and that's what the the history told us as well. Given that she's febrile, she's fairly tachycardic for someone who's so young. That's pretty concerning, especially when you factor in her low blood pressures initially. Even though in pregnancy blood pressures can be a little bit lower, I'd still be pretty concerned here. And then in terms of her exam in general, I'm sort of taking away the fact that we have a continued picture of possible urinary retention with continued signs of, whether of upper motor neuron involvement in some ways from this bilateral spasticity and involvement. And that continues to make me concerned for either a spinal cord lesion that's high enough to affect both the thoracic level as well as the cervical level as well as the lower extremities, or something even higher up. And that could definitely happen from NMO or some other condition, but I would likely be centering on that process right now. The fact that we have CVA tenderness on exam doesn't necessarily confirm a condition like pyelo, but it would certainly be concerning for that in this case. She's had UTIs in the past, and this exam with hydro, possible urinary retention, and CVA tenderness, along with signs of systemic inflammation, would definitely make me concerned for that. I realize it's a little all over the place, but going on to the labs, I guess the first thing I jumped out is 7.6. Is that related to, I guess that would be 7,600 cells. Okay. So we're not actually too concerned in that case. Like rituximab can cause a neutropenia, and I would be concerned for a neutropenic fever or neutropenic infection at that point if this were below 1,500. But here we're not really too concerned about a full immunosuppressed state. And while our hemoglobin's low, anemia in pregnancy is common. I'd be interested to see if she had an absolute iron deficiency or some other cause, or whether there were even, this were sort of an anemia of chronic inflammation because she's had so many recurrent infections as well. And then from her labs, we have an elevated lactate and a low, and that really is another sign of her, having this really sick picture as systemic inflammation and possible hyperperfusion in some locations or some sort of shock type state. The albumin jumps out at me though, because I wonder whether we have, I don't see any protein on the UA in particular. And I'd be wondering to see whether how much proteinuria there was, because an albumin of 1.3 is very low for me. And I don't know whether chronic inflammation or acute inflammation along with significant proteinuria could cause that low, but I would assume it would have to be pretty significant. Yeah, I'm just trying to figure out sort of how to put everything together into a more cohesive problem representation at this point. And really what I'm centering on is that this is a person with so many immunosuppressive risk factors and anatomic risk factors for recurrent infections, who's presenting fairly sick and signs of systemic inflammation with concern for infection or inflammation localized to the proximal urinary tract again.
Wow, Noah, beautiful thoughts, and just the summary at the end is just really incredibly expert. And I'll sort of stand on your shoulders on just a couple things, starting with the last thing you said, which is localizing urinary obstruction as an issue, and specifically proximal in her, I think is a very critical diagnostic step that we weren't certain of in the beginning. But she had a urethral abnormality that didn't fix. When that was fixed, when this diverticula was taken out, her urinary retention persisted. She had a Foley catheter put in. her urinary retention persisted. So it's not down at the bladder outlet. So that really leaves us with an obstruction that's either at the top of the bladder where the ureters come in the bilateral ureters themselves, or something higher up obstructing the kidneys, including the neurologic input. So that was just masterful, the way you worked in her neuromyelitis diagnosis into how it could fit into this inflammatory urinary syndrome. So there's proximal urinary obstruction. I think the second kind of problem I really want to highlight, as you did beautifully, Noah, is this persistent concern for glomerular injury, right? She's got the hematuria, proteinuria, very low albumin. So I think we need to go back and reopen what was her workup before for these abnormalities. When they thought she had IgA nephropathy, we really need to start investigating causes of glomerular hematuria in her, which would include urine microscopy, revisiting what serologic workup she had before, and really trying to see, are these coming from the glomeruli themselves from an intrinsic renal issue? With, however, the caveat that she's also potentially had macroscopic injury in the setting of her C-section and her pregnancy to her GU system. So while in a lot of cases we're very comfortable getting right into glomerular causes of blood findings in the urine or red blood cells in the urine, gosh, like it sounds like with her C-section and her bladder visible through a vaginal opening, we really have to worry about trauma as part of the picture, whether from the surgery itself, resultant fistulization. So just to be very transparent, in the kind of hematuria category, I think we need to start our branch points both for glomerular as well as kind of like anatomic injury to the urinary system that could be from her obstetric surgery. And then the final thing I just want to put on your beautiful discussion, Noah, is that the degree of pyuria itself, with now a urine culture that doesn't show a distinct single bacterial organism, makes it important, I think, to deploy a schema for sterile pyuria. Someone in the chat, I think, could probably put in the link to a beautiful New England Journal of Medicine review on it. But when someone has really bad pyuria and they don't grow a single bacterial organism, man, we really have to expand our differential diagnosis to other organisms, including STIs, which have come up, including atypical infections like tuberculous infection in the urine, which again, she's not quite typically at risk for, but is something to think about. So I'm not pushing the specific diagnoses at this point, but I think we really kind of got onto something with proximal urinary obstruction, concern with hematuria being glomerular versus anatomic or large injury related, and then the pyuria as well. I think going forward, what do we do? Hopefully Anne-Marie will give us more data about the intrinsic renal injury workup. Unfortunately, it sounds like this woman really was in way too much pain to get more anatomic imaging, but it might be worth trying to get that pelvic MRI again to get a better sense of the anatomy. And then really think broadly about systemic or infections, right? Looking for more than the standard bacterial, both in terms of urine as well as kind of serum assays and cultures as well. Let's leave it there because there's probably a lot more. Anything you want to add?
Can we just I'm trying to brainstorm like what viral infections could potentially wreak havoc in the GU kind of mucosa in the context of rituximab specifically? Taylor, Noah, can y'all think of any? I can only think of like a couple, but.
Kuchal's mentioning, BK virus. It's a good, good thought. We think of very frequently with renal transplant, right? But this is a situation where it really could be relevant, and we should think about that. That's a great thought, Kuchal. And adeno. Yeah, adeno was the one that I know in people with certain types of immune suppression can just cause really bad systemic disease, but has a particular predilection for the GU mucosa. And then I think like just herpes simplex and potentially other herpes viruses too, but simplex in particular, I feel like I've been kind of I've heard a lot of dermatologists say that, especially in the setting of immunocompromise, like it won't look like you think it's supposed to in terms of just vesicles on a normal base. A lot of times it can just be friable, inflamed mucosa. And to your point, Steph, of like
could this be an upper tract obstruction? That's one way where invisibly, right, and non-extrinsically, the ureters could be inflamed, strictured, obstructed, and causing this progressive hydronephrosis.
Or even with primary herpetic infection, the neurologic damage being from that instead of her
Interesting.
neuromyelitis.
Good point. And saying that the blood might be actually anatomic hematuria, but there's definitely proteinuria. So could this actually be a nephrotic syndrome up in the kidneys? And isn't membranous nephropathy associated with herpes? I feel like I've always seen HSV on a list of causes, but I've never actually like seen or heard of a case of that being associated. But one way to tie like this extremely multi-pronged case a little bit closer together.
Give us more, Anne-Marie.
Okay, awesome discussion so far, everyone. So the urine culture was obtained and again negative, was started on vancomycin and pip/tazo at admission. Urology was consulted and nephrostomy tubes were placed. The urine culture from both nephrostomy tubes were negative. Blood cultures did grow 2 out of 2 for Staphylococcus epidermidis and 1 out of 2 for Staphylococcus capitis. Received an MRI of the abdomen and pelvis with contrast, which was suggestive of a urethral vaginal fistulization, urethral enhancement with early abscess formation. It did show improved hydronephrosis after the nephrostomy tubes were placed. Repeat blood cultures were obtained after antibiotics and were negative. A TTE showed no valvular lesions. Had received kind of extensive autoimmune workup, which remained negative. Neurology had consulted for the endono and spinal imaging, did not show new active lesions, so was thought to be at baseline as far as that goes. I was gonna maybe have this 2 aliquots, but I think just because of time, I'm gonna just like go up to the case conclusion if that's okay with everyone. So throughout hospitalization, continued to have fever and leukocytosis, had gotten these repeat CTs showing complex multiloculated abscesses that continued to grow despite antibiotics. So had received 3 weeks of vancomycin therapy. The pip/tazo was switched to meropenem, but kind of continued to have these symptoms with possible emphysematous pyelonephritis as well. Received aspiration of the abscess with VIR with negative anaerobic and aerobic cultures. Continued to fever, and so got repeat blood and urine cultures, COVID testing that was negative. Gonorrhea and chlamydia testing were negative as well. Received a repeat aspiration of the renal abscess without growth, and this time got AFB and fungal cultures, which were also negative. Was having some diarrhea, so got C. diff and GI pathogen panels as well that were negative. So at this point is 4 weeks into the hospitalization and having increasing size of the abscesses, continued fevers, now has like worsening mental status. IgG levels are checked and are low at 493 with decreased CD19 cells. And so kind of at this point is kind of where a diagnostic test was sent.
Holy moly. Thanks, Anne-Marie. What do you think, Taylor?
Okay, so basically just, to start, she comes in, these are her vitals. She's definitely sick. So she is someone who, if I was taking care of, like if this was my admission, I would not hesitate to start empiric antibiotics as was done. And of course, ID and GU would have been on board like first and foremost when I was putting all the orders in, because, we need consultants to help better take care of the patient. And then, so the fact that we had abscesses, it was nice because we could like culture those. But I guess it looks like not much really came from that. So, but that's just, something to keep in mind. And Okay, so I guess the IgG low CD19 cells. So I guess a diagnostic test was sent. I don't know what that diagnostic test would be, to be honest. But low IgG, something with her immune system. And luckily we have Dr. Up to Date, which I use multiple times a day. So I would be up to dating hour in, hour out, and just, getting help from Up to Date. So I don't know what diagnostic test would be sent. What I do know is, there's some immune dysfunction going on. And I'm curious to see what the final diagnosis is, because I have absolutely no idea.
Noah, other thoughts or wish list of things you think we should send at this point?
I am also, very excited to figure out what it is, but also, a little bit confused. I'm sort of thinking, like this abscess is interesting to me. I wonder whether there's another, an abscess formed from this gonorrheal infection. Maybe it was PID and subclinical and formed a tubal ovarian abscess, which can also often be retroperitoneal, and maybe could have led to some of that fistulization along with the scarring, and could be in some of this process, but for something like that, I would wonder whether a culture aspiration or a tissue culture would help, but that would be a little bit risky. And I don't know whether that would be something I would be interested in if they got, but also sort of complex infectious workup. I think Kushal mentioned Acarius, and Acarius would definitely tell us. I guess the next question about Acarius is which fluid do we get it from? Maybe. I don't know whether you can get it from the blood or the urine. I don't know what it's, I've never had it sort of employed it before, but would be interested to see whether you can do that, because it seems either an atypical bacteria or some sort of viral infection, or even a slow growing mycobacterial infection could be the cause here.
Thanks, Noah and Taylor. I'm similarly stumped, and I think you guys are thinking about it in a perfect way. And just to kind of summarize the framework that y'all kind of brought up and that I would use here is, our culture, our microbiologic techniques are not perfect, right? So even though we have taken fluid, sent it to the lab, there's some organisms that don't grow on those routine cultures. In the setting of having been on antibiotics and all those things, sometimes even it can be a more like plain vanilla organism and not grow in culture. So so that's one possibility, and that's where the universal PCR for, that's what a Acarius is. It's a PCR for basically like hundreds of pathogens, just kind of like a shotgun of like look for everything. Oftentimes will give a somewhat surprising, not considered kind of rare microbe, or one that again was just harder to test for in other ways. And you made a list, and I think Kushal in the chat at some point it popped up, but mentioned that ureaplasma is another organism that can colonize, or you can get contract also, that can kind of behave this way. And the other angle to look at this is, what are our gaps in antimicrobial coverage, right? So even with the abnormal immune system, to have such progressive disease on PIBTAZ, and VANC makes a lot of things a lot less likely. Whereas, the absence of doxycycline or or a quinolone that would cover an organism like ureaplasma makes that more likely. And then absolutely mycobacteria and other things very much in play with the rituximab and everything. The low IgG, I think that's just a sort of depletion from rituximab. I don't know if that directly kind of factors into the case, but wow, this was an amazing case, Anne-Marie, and wonderful discussion by Noah and Taylor that I'm just really happy to be a part of. But Anne-Marie, teach us what happened to this patient and what we should learn from it, along with Andrea. Bring us home.
Okay, so PCR testing was sent from the renal abscess for ureaplasma urolyticum, which was positive, and was started on double therapy with doxycycline and fluoroquinolones, which Kushal had ureaplasma like first thing, which I'm not surprised about. So a little bit about ureaplasma. It's fastidious and it also does not have a cell wall, so it won't show up on gram staining. So the identification is on mycoplasma specific transport media or PCR testing. It colonizes the vaginal flora of up to like 40 to 80% of sexually active females, but in transplant patients, it can cause disseminated disease, which can also manifest as an increased ammonia level that can actually be fatal. Was not present in this case, but also there have been cases with rituximab use in renal abscesses. So we were just missing it because every agent was a cell wall active agent. And since ureaplasma does not have a cell wall, it will not respond to that. So I'm excited to hear the teaching points.
Hi, everybody. This was definitely a very challenging case. And I really like the idea or the key that first start with a recent complaint and then go back, because it is very difficult. In this case, with so many things going on, you can get overwhelmed. So I really like the point to first start with a recent complaint and then try to go back and think conceptually. We have a patient that has a systemic inflammatory disorder and can be immunosuppressed and makes you think of potential opportunistic infections. This patient have neuromyelitis spectrum, Optica spectrum. It's a spectrum of disorders that tend to behave similarly, and it causes severe inflammatory debilitation of the CNS. Is different than multiple sclerosis, and it tends to appear around the 30s, and it is related to B-cell autoimmunity. That's why she was given rituximab. And the common presentations include decreasing vision, and it can also cause myelitis. That's why we talk about it when we did the neurological evaluation. Something good that I really liked was that Taylor mentioned that it's important to consult surgery specialties for anatomical complications that may be not so common for internal medicine. And we thought how rituximab can create trouble clearing a common UTI or reactivates an infection that the patient already had. Then we have the patient had anemia, so since she was peripartum, we thought maybe it was due to the pregnancy or chronic inflammation. And when we talk about the hematuria, we thought anatomically that it can be due to damage in the glomerulus or trauma due to the surgery that she had. Maybe it can have caused a fistula. And we did this mental exercise to think about viral infections that cause GU mucosa damage, like BK virus, adenovirus, and herpes. That doesn't present as you think you will be. It can present with friable mucosa. And then we learn about this test that I had never heard before, but sounds awesome. The Carius test that allows to sequence microbial cell-free DNA, and it can identify over 1,000 clinical relevant pathogens. Thank you very much to everybody. See you next time. Bye.
Bye, everyone. Thank you. Thanks again to everyone. Great to see you. Have a great afternoon, evening, morning.
Bye.